Hi, good evening, everyone. So, this evening we'll be doing something different from the previous weeks that we were usually discussing one biological every week and try to understand how they work in psoriasis and what all parts of the axis in the inflammatory management are we targeting by using these different drugs. Now, I received multiple comments that we should also discuss few important guidelines, and we will discuss only two of the most important guidelines, which is American Academy of Dermatology and British Academy of Dermatology. I won't be discussing the Indian scenario and Indian guidelines because few properly made guidelines are still lacking in the Indian scenario, and it's better that we read and refer to individual articles regarding each biologics and specific constraints and clinical scenarios of our patients, and then decide whether biological could be given or not. Now, in these Western countries, the biologicals are paid by the insurance people. Okay, that's why they have become the first line regimen in treatment of psoriasis. While most of our patients would be, they won't have good amount of insurance, or they won't have insurance that provide coverage for these biologicals. So it becomes much more difficult for to start straight away with biological therapies. So that's why the scenario in the Indian context is a bit different as compared to the British or the American context. But at least if every drug in your armamentarium is okay to use, it's allowed to use, and you are more familiar with using all types of drugs, then should be the protocol for starting, or what should be the currently available evidence regarding the use of biologicals in different types of psoriasis. Okay, so there is a certain different aspect, there is a certain different way in which you take information from a guideline. Guidelines are supposed to guide you. They are not like strict instructions that is only you can do. These are the ways that you can proceed only in. You cannot break the protocol, but you should have a proper and a good medically sound reason to break protocols. Guidelines are supposed to inculcate or incorporate the available evidence, the available articles, and thus make it in a explain it in a lucid manner how and why and in which scenarios we can use these biologicals. Okay, so you might find the guidelines a bit repetitive and a bit difficult to remember and understand. But remember, you don't have to memorize all these guidelines per se. You just need to know what level of evidence or what grade of recommendation you have. Okay, so the one good thing about biologicals is that a lot of studies have been done in the West, which are majorly randomized controlled trials. They may be placebo compared to a placebo, or compared to another biological which is considered as the mainstay of treatment. So we'll be discussing one biological in comparison to other and just giving you points that what is the grade of recommendation for each biological. And these biologicals will be, this recommendation will be as per the American Academy of Dermatology. Now what the British Academy does is it just gives you recommendation that what should be done in one scenario or what should be done in another scenario. So it's not that only on certain aspects the British Academy is going to recommend a certain biological, while what the American Academy does is they discuss each and every biological separately, trying to give different grades of recommendation that this biological is recommended as first line for this type of psoriasis. This regimen of that biological is recommended first, and it all depends on the available literature. So remember that the guidelines can change because the available literature is changing day by day or month by month, and you should also keep in mind that regular updates of these guidelines do come. So I'm discussing the most recent update to psoriasis guidelines, and just keep an eye out if some newer update comes, and you might need to update, or even I might do another video and update the guidelines. Okay, so with that being said, we will start again with guidelines in dermatology in psoriasis, and we'll be discussing the American Academy and the British Academy of Dermatology. Okay, so let's start. Now remember that this disclaimer is given in the American Academy of Dermatology. It says that adherence to these guidelines will not ensure good treatment. So it doesn't, the insurance, or you could say it will not ensure that your patient would heal. Okay, so that's one point. Another point B, it should not be interpreted as setting a standard of care. That means these guidelines are not telling you to change your particular protocols. These are just guidelines, they're guiding you. Okay. Ultimate judgment must be made by the physician and the patient. Each case is different. So you cannot have a biological which is suited for all scenarios. Okay, for example, Certolizumab Pegol is one of the best biological to be used in pregnancy, but we don't have access to it. So that doesn't mean that we are not going to give any biological to a pregnant woman. We'll consider other biologicals. So the ultimate decision always lies on the discussion between the physician and the patient. The treatment dosages used in clinical trials may not be effective in certain cases. So what this guidelines gives you as a grade of recommendation is dependent on the available literature. If a RCT, if a randomized controlled trial shows that one type of regimen is better than the other type of regimen, then it will have a higher grade of recommendation. Okay, but that doesn't mean that it has a higher grade of recommendation that it is the best dose for the patient. You are allowed to tinker around with those doses depending on whether you have a medically sound reason to change those regimens or not. This guideline reflects the best available data. As I said, the data keeps on changing, so you must make sure that you keep yourself updated and will require revisions. Of course, because the data, whenever newer RCTs keep on getting reported and published, the guidelines will require a certain amount of upgradation and it may change the grade of recommendation. Now, starting from the grade of recommendation, we'll just discuss what do we mean by grade A, grade B, and grade C. Okay, so we will be discussing, as per the American Academy of Dermatology, each and every biological, and I'll be discussing each and every biological under three headings. These three headings are: one is A, two is B, and C. So these are the grades of recommendation. Okay, so grade A is the best grade of recommendation. It is based on consistent and good quality patient-oriented evidence. Okay, so what is patient-oriented evidence? It is evidence that measures the outcomes that matter to the patient. For example, morbidity of disease, mortality from the disease, improvement in symptoms, reduction in cost, and improvement in quality of life. Okay, all the factors. So if RCTs or case control studies or double-blind placebo-controlled studies, double-blinded RCTs are available, and if they mention about improvement in quality of life or improvement in symptoms or improvement in decreasing the cost, if that data is available for that biological, then that biological has a grade A recommendation. Okay, now grade A is inconsistent or limited quality patient oriented evidence. The evidence is still patient oriented: morbidity, mortality, symptoms, you know, and decreased quality of life, quality of life. The data is still there, but it's not that good, that robust to give a grade A recommendation. So it gets a grade B recommendation. And grade C are recommendation based on opinions, case studies, or disease-oriented evidence. Okay, disease-oriented evidence, for example, reduction in PASI, or reduction in pruritus, or subjective improvement. So you can have this kind of changes in after you use a certain biological, but that doesn't necessarily translate into better quality of life for the patient. So that is why it has the least grade of recommendation, which is C. We are clear on that. So remember what is A, what is B, and what is C. Okay. So let's start with the first biological, which is Adalimumab, receiving FDA approval on January 22, 2008. Adalimumab has grade A recommendation as a monotherapy, that means only Adalimumab, in moderate to severe plaque psoriasis, okay, in palmoplantar psoriasis, in nail psoriasis, and if any of these psoriasis have psoriatic arthritis, it can have a grade A recommendation. So Adalimumab is recommended as per grade A recommendation in all of these things. Okay, the regimen of Adalimumab that is given recommendation of A is the same recommendation that we have discussed previously in individual videos. I'm not repeating it again because subsequently you will get confused between all of these regimen. I would advise to go back and view the individual videos, so where I've explained it a bit slower, and just remember that the regimen that I've explained in those videos are the FDA approved regimen, and those are the regimen that has grade A recommendation. Third grade A recommendation is that Adalimumab maintenance dose 40 mg a week works better in disease control in some patients. So remember that maintenance dose of Adalimumab is 40 mg every 2 weeks, but there is also a recommendation that you can decrease the duration to 1 week, and it has led to better disease control in some patients. Clear? Grade B recommendation for adalimumab is monotherapy. That means only adalimumab in scalp psoriasis, pustular psoriasis, erythrodermic psoriasis. Now, just few points to make it easier to understand. Pustular psoriasis will always be mentioned with erythrodermic psoriasis in 90% of the cases. So it becomes easier to remember. Okay. And psoriatic arthritis and moderate to severe plaque psoriasis is a grade A recommendation for nearly all biologicals. Clear? It has a grade B recommendation as a combination with high potency corticosteroid plus minus vitamin D analog. Also, a combination with adalimumab and methotrexate and a combination with narrowband UVB has a grade B recommendation. Now, another trick to remember is high potency corticosteroid plus minus vitamin D analog will always be mentioned together. So, either you give one of these two or give both of them. That will have a same grade of recommendation. For adalimumab, that is B. Clear? The grade C level of recommendation or the strength of recommendation, I'm misquoting, the grade of recommendation of C for adalimumab is with combination with acitretin, apremilast and cyclosporin. Okay, so that means that as of now there is limited data available to combine adalimumab with acitretin, apremilast or cyclosporin. Okay, so whenever you're thinking of combining these two drug classes, remember that as of now the grade of recommendation is only C, and you may combine with other drugs which have better grade of recommendation, namely methotrexate or narrowband, which has recommendation of B. Okay, so you get the hang of it, how they have divided each biological as A, B and C grade of recommendation depending on the data that is available and the robustness of the data that is available. So going to now coming to our second biological, which is Infliximab, which received the approval on September 27, 2006. The grade A of recommendation for Infliximab is as a monotherapy. That means only Infliximab for psoriasis and psoriatic arthritis. These two disorders are going to come hand in hand for every biological, psoriasis and psoriatic arthritis. The infusion dosage is 5 mg per kg and the regimen is as I have described in the previous individual video. It's the same FDA approval regimen. So that has been given a grade of recommendation A. Also, it inhibits radiographically detected damage of joints in patients with psoriatic arthritis. That means if you have a patient suspected of psoriatic arthritis and there are changes on the X-ray, Infliximab becomes a better drug because it has shown conclusively to reverse the sign or inhibit the signs of joint damage in psoriatic arthritis. So in those patients, you can consider Infliximab as one of the first choices of biologicals. For Infliximab, grade B recommendation is given for administering at a shorter interval. Now remember that in maintenance phase of Infliximab, the IV infusions happen at every 8 weeks. But you may shorten the interval to every 4 weeks, and this has received a recommendation of grade B as per the American Academy of Dermatology. So either you can decrease the duration to 4 weeks, the interval to 4 weeks, or you can increase the doses to 10 mg per kg. Okay, remember that Infliximab is used roughly around 3 to 5 mg per kg doses, but you can increase to 10 mg per kg. If you go back and see the video on Infliximab, you will see that I was discussing 3 to 5 mg per kg and dose escalation to 10 mg per kg. So this was regarding that. This dose escalation is given only a recommendation of B as per the American Academy of Dermatology. Monotherapy of Infliximab in palmoplantar psoriasis, nail psoriasis and scalp psoriasis is also given a grade of recommendation B. Combination of Infliximab with high potency corticosteroids and or vitamin D analog or methotrexate is given a grade of recommendation B. Remember that the grade of recommendation for Infliximab in combination is B. The grade of recommendation C for Infliximab is for monotherapy in pustular and erythrodermic psoriasis, which I've said is usually come together. So pustular and erythrodermic psoriasis, and in combination with acitretin and apremilast. That means the data is lacking as of now, It has shown changes in disease activity, but not per se as patient-oriented data. Discussing our third biological, which is Etanercept, which got approval in April 30, 2004. The grade of recommendation is A for using Etanercept as a monotherapy in chronic plaque psoriasis. Now, remember that every biological is approved as a treatment for moderate to severe chronic plaque psoriasis. So, whenever I say psoriasis, I mean chronic plaque psoriasis or moderate to severe variety. Okay. So, grade of recommendation A is given as a monotherapy for Etanercept to be used in psoriasis, scalp psoriasis, nail psoriasis, and psoriatic arthritis. Okay. The regimen is same as we had discussed in previous videos. I'm not repeating it. Also, 50 milligram twice weekly is more efficacious than once weekly. Remember that in the maintenance phase of Etanercept, we were giving 50 milligram a week subcutaneous injection, subcutaneous weekly. But it is said that if you give two injections of 50 milligram two injections in a week, that means you give every third day 50 milligram, it has led to better disease control. It has led to increase in efficacy of Etanercept. Combination with high potency steroids and or vitamin D analog is also given a grade of recommendation A. For Etanercept, the grade of recommendation B is for pustular and erythrodermic psoriasis. So it's one of those biologicals whose use in pustular and erythrodermic psoriasis has been given a grade of recommendation B. Combination with acitretin, methotrexate, and narrowband UVB has given a grade of recommendation B. Clear? So if you look at the grade of recommendation as per the American Academy of Dermatology, you will realize that Etanercept is one of the most favored biologicals there. That is why you have so much study going on, so much data available, that you are able to give better grade of recommendation as compared to other biologicals. For Etanercept, the grade of recommendation of C is given as given in combination of cyclosporin or apremilast. That means, as of now, the data regarding the efficacy of Etanercept plus cyclosporin or Etanercept plus apremilast is lacking. So the grade of recommendation is going to be C. Okay, but you have realized by looking at this presentation that Etanercept has much better grade of recommendation in different types of psoriasis, predominantly as a monotherapy and preferably as 50 milligram twice weekly regimen. We are clear on that? Let's move on to the next biological. So the fourth FDA-approved TNF-alpha inhibitor is Certolizumab Pegol. It's not available to be used here, but we need to discuss it faster, but it will be over in a jiffy because we have only one slide on this. Certolizumab Pegol got approval on May 27, 2018. Okay, and there is no good evidence available to give any grade of recommendation. No recommendation regarding treatment combinations, no recommendation regarding efficacy in difficult to treat areas, no recommendation regarding immunogenicity. So the data is still not available. As you know that it got approval in 2018, so still studies are ongoing. It needs to be reported and then incorporated into the guidelines. But it is touted to have characteristics similar to other TNF-alpha inhibitors. So you can learn a bit about certolizumab by extrapolating the data available from other TNF-alpha inhibitors. Okay, so we're clear on that. So till now, we have heard about American Academy of Dermatology recommendations on 4 TNF-alpha inhibitors: Adalimumab, Infliximab, Etanercept, and Certolizumab Pegol. Now we'll be discussing some general comments about TNF-alpha inhibitors. Now, if you go and read the AAD guidelines in full detail, they have huge tables in which they give general comments on TNF-alpha inhibitors. About 80 to 85% comments have been discussed when I was discussing about individual drugs in their own videos. Just as a quick reminder of these points, and just as if I found something different in AAD guidelines, I mentioned here. Okay, So I request you to go. I will provide links to AAD guidelines, where you can go and access the PDF and download it and read it for your own. It's a 44-page guideline. Just go through it, and you will find everything in detail. I'm just summarizing them for a quick review for understanding. Okay. The AAD recommends that you should assess the response after 12 to 16 weeks, except for Infliximab, where you assess at 8 to 10 weeks. So if you remember the older videos, we used to say that at week 12 you see the response. If week 12 the response is not adequate or not there, you stop with the biological and consider different therapy. For some of the biologicals, it is week 16, but 12 to 16 is a good parameter where you can see the response if it is adequate or not. Okay. Obese patients respond poorly. Now remember that many of those drugs require a weight-based increase in the doses, and obese patients have increased inflammatory background, increased comorbidities, increase difficult to treat psoriasis, and they would require more doses of different biologicals, so they will respond poorly. For malignancy, the American Academy of Dermatology says that it is not increased with monotherapy. It may increase with combination with other immunosuppressives, namely methotrexate or Tuva or narrowband or Sorelens or cyclosporin or azathioprine. So malignancy is not increased with monotherapy of biologicals, but it may increase with combination with other immunosuppressives. Patient with history of solid tumor malignancies can be given TNF alpha inhibitors, but you require a proper follow-up. You should have good you should have good observations regarding different malignancies, so that you can catch them, stop biologicals, and provide specific treatment. Okay, let's go further. If your patient has HIV, the near all biologicals discussed so far can be given only if the patient is on heart therapy, if the CD4 count is normal, and there is negligible viral load with no opportunistic infections. Okay, so let me just do that again. If your patient is of HIV, all biologicals can be given if the patient is on heart regimen. Yeah. So if your patient has HIV, you can still give biologicals provided that the patient should be on heart regimen, the CD4 count should be normal, the viral load should be negligible, and there should be no opportunistic infection. So remember that while we're discussing individual biologicals, no point or no source of infection should be present before starting biological. Hep B and Hep C, if a patient is suffering from hepatitis, biologicals can be given after control with antivirals for active disease. Okay. TNF alpha inhibitors can be given for inflammatory bowel disease. In fact, biologicals like Infliximab are biological of choice for inflammatory bowel disease. Biosimilars. If you want to, let's say, switch between one biological into another biological, one TNF alpha inhibitor with another TNF alpha inhibitor, you can only make the switch between FDA-approved biosimilars only. And the similar guidelines will apply to the secondary biological also. For tuberculosis, the American Academy of Dermatology mentions that annual screening should be done. If your patient has high risk of TB activation, for example, there's a TB history or there's a TB contact in the family or workplace, quantiferon gold should be used. While in low risk patients, even chest X-ray would be enough. Okay. And remember that when you are looking at hepatitis B, you have to monitor the patient with hepatitis B surface antigen, anti-hepatitis B core antibody, also liver function test. See if the hepatitis is active or not. If it is not active and it's in remission, negligible viral counts, biologicals can be easily given. Remember that as of now in the Western countries, biologicals is one of the mainstay and most efficacious therapy, having least amount of side effects for psoriasis. Okay, so they want patients to get advantage of biologicals as soon as possible, and anything that might delay patients' access to biologicals should be taken care of. Patients should not suffer from unnecessarily delays. Okay, so it's better that you monitor your patient with LFTs, you monitor for viral counts and etc., so that you know that it's not getting reactivated. The American Academy of Dermatology says that in pregnancy and lactation, the biologicals are safe. In men who want to undergo, want to plan a family with their partners, it is biologicals are considered safe. There is a theoretical mention that fetus or neonates and infants should be considered immunosuppressed for at least 1 to 3 months if the mother had received biological therapy during pregnancy. So remember that these biologicals are a modification of IgG class of antibodies, and IgG crosses placenta. So whenever the antibodies are going to cross the placenta, it will reach the fetus or the baby, and it is very prudent to make sure that you consider the fetus or the newborn as immunosuppressed for at least 1 to 3 months till the time those IgG class of proteins are degraded naturally by the baby and removed from the system. Okay, but that is a theoretical aspect. You may not stop a pregnant female to for getting a biological therapy just because she is pregnant. It's better to have a discussion with the patient, weigh the pros and cons, weigh the advantages and the risks, and then decide to give biological therapy under proper scrutiny, or just make sure that you keep a good follow up with the patient and of the baby also, and consider the baby immunosuppressed for the next 1 to 3 months till the IgG class gets degraded by itself. Okay. Remember the first slide that we were discussing about the disclaimer one? The final treatment option should always be done after discussion with the doctor and the patient. What they are going to discuss among themselves. So this slide, I'll just shift my video so I can go behind the table. Yeah, looks better. So this slide is maybe one of the most important slides. I've tried to summarize everything in this particular table. You can click a screenshot and save it to yourself. This slide summarizes all the recommendations, all different grade of recommendation for TNF alpha inhibitor as per American Academy of Dermatology. Okay, so grade A recommendation for Adalimumab is in psoriasis, psoriatic arthritis. It is for the recommended infusion and better controlled by 40 milligram per week rather than every 2 weeks. Same is for Infliximab, Etanercept, and Certolizumab Pegol has no data, so I have not mentioned it here. Okay, so all the short forms I've given here, what do they stand for? I've given the grade of recommendation in green, the grade of recommendation in B and C. Okay, and pustular psoriasis, erythrodermic psoriasis, scalp psoriasis, combination with different regimens. So this slide is going to summarize whatever the American Academy of Dermatology has given as grade of recommendation for all the 3 or 4 TNF alpha inhibitors for psoriasis. So what I'm going to do is I'm going to remove all the markings and I'll wait for 5 seconds, and you can not do anything. You can take a screenshot and save it in your phones so that you can review it whenever you want to revise or read about it. Okay, so let's move forward. Okay, so next biological that we'll be discussing as per American Academy of Dermatology is Ustekinumab, which received approval in 2009, September 25th. The grade of recommendation for Ustekinumab is grade A for monotherapy, that means only Ustekinumab in psoriasis and psoriatic arthritis. The regimen is same that I've described in the individual video, so I'm not repeating it again. And also the American Academy says that higher doses and shorter intervals in the maintenance phase can be tried if there's inadequate response. That means following this regimen, if you don't have adequate response, that you may either increase doses, that means 45 milligram can be increased to 90 milligram, or you can decrease the interval. For example, it's given every 12 weeks, you can decrease it to every 8 weeks. if the response is inadequate. So that changes in guidelines have also been given as a grade of recommendation A for Ustekinumab. Clear? Grade B recommendation for Ustekinumab is given as a monotherapy for palmoplantar psoriasis and nail psoriasis. Also, combination of Ustekinumab with acitretin, methotrexate, narrowband UVB is given grade B recommendation. Clear? Now, grade C recommendation for Ustekinumab. Grade C recommendation for Ustekinumab for monotherapy, that means using only Ustekinumab, is provided only for scalp psoriasis, pustular psoriasis, and erythrodermic psoriasis. Remember that pustular and erythrodermic go together. Combination of Ustekinumab with high potency corticosteroids or vitamin D analogs or a apremilast or cyclosporin has a grade C recommendation. Yeah, grade C recommendation. So corticosteroids, vitamin D, apremilast, cyclosporin, use any of these drugs along with Ustekinumab. It has a grade C recommendation. Clear? Now the academy has some general comments about Ustekinumab. It says that you have to assess the response after 12 weeks of continuous therapy. Okay, so for Ustekinumab, it is 12 weeks. It does have a weight-based dose modification. So because just remember what the criteria for, what the recommended regimen for Ustekinumab is. If the weight is less than 100 kilograms, you give 45 milligram doses. If the weight is more than 100 milligram, you give 90 milligram doses. That means 2 syringes of 45 milligram. For patients who have HIV, hepatitis B, hepatitis C, it is same as TNF-alpha inhibitors. It can be given if the patient is on treatment, negligible viral load, no opportunity infection, and CD4 counts are okay, normal. It can be given in inflammatory bowel disease or multiple sclerosis. Now, there are just few points that the Ustekinumab has received FDA approval for psoriatic arthritis. Okay, but the action on the reversibility of joint damage is not that proper as TNF-alpha inhibitors. Okay, so if your patient is currently receiving TNF-alpha inhibitor with good response on the joints but not so good in psoriasis, or even good response in both, and for some reason or the other you need to shift that patient from TNF-alpha inhibitors to Ustekinumab, there might be a slight chance of worsening of arthritis. Okay, so just keep that in mind that arthritis might worsen if you shift from TNF-alpha inhibitor to Ustekinumab. Clear? For Secukinumab, which got the approval on January 21, 2015, and one of the most commonly or most varied use of biologicals in India is Secukinumab. Okay, so this interleukin 17 inhibitor has received grade A recommendation as a monotherapy for psoriasis, nail psoriasis, palmoplantar psoriasis, and psoriatic arthritis. The regimen is same, and also if you replace 150 milligram with higher doses, which is 300 milligram, it shows more efficacy as compared to the half dose. So there are regimens available which use 150 milligram just to cut down the cost of the regimen, but 300 milligram is found to be more efficacious, more effective than 150 milligram. You're clear on that? Now remember that sometimes you might want to decrease the duration between two doses in the maintenance phase. For example, instead of giving 300 milligram every 4 weeks, you can give 150 milligram every 2 weeks. So this kind of dose modifications are allowed, or given that you should have a good medical evidence for changing this regimen. Let's say your patient responds very well with 150 milligram, but the response lasts only for 3 weeks, not 4 weeks. Then it's better to shift to 150 milligram every 2 weeks. If the response is poorer for 150 milligram, it's better to increase the dose to 300 milligram every 4 weeks. You're clear on that? So you can do this kind of modification, but it should have those evidence. Grade B strength of recommendation for secukinumab is as a monotherapy for scalp psoriasis and palmoplantar pustulosis. Now, this is not palmoplantar psoriasis, this is palmoplantar pustulosis for secukinumab. Grade C recommendation is erythrodermic psoriasis. Now remember, this is the only biological till now that we have heard that pustular psoriasis is separate from erythrodermic psoriasis. Okay, so pustular psoriasis recommendation is grade B, and for erythrodermic psoriasis the recommendation is grade C. Now this is again that same sort of table that I had made for TNF alpha inhibitor. I'll just remove my cursors on the side and I will not write anything. You can click a screenshot and save it on your phones. And this is just a little bit of summary for Ustekinumab or Secukinumab with what all recommendations are for psoriasis, what all diseases have a grade A recommendation, what all combinations have a grade B or grade C recommendation. So you can just have a screenshot of this and keep it with you so that you can revise it and then easily write a lot about each of these biologicals. Now, American Academy of Dermatology, in the end of those guidelines for biologicals in psoriasis, have I think 1 page or 1.5 page about different kind of peripheral services that a doctor should provide to their patients. So they are mentioned as some roles of dermatologists. That means a dermatologist is responsible for complete patient education. So any information regarding the biologicals should go through dermatologists rather than internet search or Google searches. It's better that the doctor has a good detailed discussion about the biologicals, the regimen, the adverse events associated, the dosing schedules. So if a patient who cannot come to you every 2 weeks or every week to get those injections, it's better you switch to Infliximab that has like 2 monthly maintenance phase. Okay, so you can give that. If a patient cannot come for IV infusion, cannot get admitted for IV infusion, then consider Etanercept or Secukinumab so that patient can take himself as subcutaneous pre-filled syringes. Okay, so complete education should come from a dermatologist. All data regarding efficacy and safety should be discussed with the patient. Quality of life indicators like DLQI should be used. Discuss the cost and the routes of administration. A patient might be more comfortable with IV infusion rather than self-medicating with self-subcutaneous injection. Other patients might be very well versed with very well educated to take subcutaneous injections on their own rather than coming to the hospital and getting an IV infusion. So all of these things have to be discussed. Now, other consideration that the American Academy of Dermatologists mention is in case of primary and secondary failure. Now, what do we mean by primary failure? Primary failure is, let's say after discussion you have decided to use Adalimumab in your patient. You start giving Adalimumab and at week 12 it is not showing you any efficacy. That is known as primary failure. That means the first biological didn't work adequately. Secondary failure is when the biological that you want to give has good response initially, but now the patient is relapsing. Okay, so during initiation phase or maintenance phase, the biological was working perfectly, but now the patient has started to have the disease activity again using the same regimen of that biological. That is known as secondary failure. Okay. Discuss TNF alpha inhibitor versus other biologicals. Other biologicals is interleukin 12-23 inhibitor is Ustekinumab and interleukin 17 inhibitor like Secukinumab. Okay. Now, when to restart those? Let's say a patient was not able to come to you for proper visits and you were not able to inject the patient or administer the biological. So if few doses are skipped, let's say a biological was supposed to be given every 2 weeks and they have skipped 2 doses. So start again the maintenance phase. Okay. But let's say if the duration is more than 3 to 4 half-lives of the biological. Okay, every biological has a half-life we have discussed in the individual videos. If 3 to 4 times this half-life has elapsed between the last dose and the current visit, it's better to restart. Restart again with the initiating phase, induction phase, and the maintenance phase. Okay. If the disease is flaring, and what do we mean by flaring? Flaring means it has reached the baseline activity or maybe more than 50% the baseline PASI score. That is known as a relapsing disease, a disease which is coming back. And this time it is coming back because of inability to take the doses. So you restart the whole regimen again. You restart the maintenance phase, you restart the induction phase again, followed by the maintenance phase again. Disregard the previously given doses. You can only continue the regimen with only if only few doses are skipped and the disease still remains well under control. Now, if we want to switch from one biological to another for whatever the reason that we may have, there is no definitive data per se. Okay, there's no fixed data, but remember that any biological can be switched to any other biological, but they both should be FDA approved. Yeah, there should be only FDA approval switches. There is no recommendation regarding wash off period, but it is just said that 3 to 4 half lives of that biologicals is good enough. Okay, so if the patient is on biological A and you want to start biological B, the gap between two biologicals should be roughly 3 to 4 half lives of what biological? Of 3 to 4 half lives of biological A, so that to give adequate time for the biological A to get removed from the body system and you can then start with B. Any biological can be switched depending on the preferences. Let's say you started on Infliximab, now the disease under control, patient cannot come so frequently for IV infusion, you want to switch to Adalimumab or Secukinumab, so you can make that switches. For any surgery, for any minor surgery, the biological can be continued. You don't have to stop the biological. If there's a major surgery, and what do we mean by major surgery? That means general anesthesia is required, or there is breach of oral cavity, breach of anal cavity, GI tract, respiratory tract, anywhere where chance of infection becomes substantially higher. In those kind of major surgeries, it's better to stop 3 to 4 T halves before, 3 to 4 half lives before, and until 1 to 2 weeks after the elective surgery. Okay, so you stop 3 to 4 half lives before the surgery, get the surgery done, wait for 2 weeks, and then restart the biologicals again from the induction phase and then the maintenance phase. Okay, same regimen can be used if live vaccines are absolutely essential to be given. Same, you stop, wait for 3-4 half lives, give the vaccine, wait for 2 weeks, restart the biological. Clear? Okay, so let me just explain before going to the British Association of Dermatology guidelines. So if the patient is on biological, you stop the biological, let's say biological A, you stop it from 3 to 4 T half, and then you let the patient undergo major surgery, and then you wait for 1 to 2 weeks, and then you restart A. Clear? Am I clear on that? Okay. If the patient is on a biological, you stop, wait for 3 to 4 half lives regarding that biological, get the surgery done, and 1 to 2 weeks after the surgery, you stop, but keep stopping the biological, and then you must start again. And remember that since 3 to 4 half lives have passed, it's better to restart the whole regimen again. Clear? Now, with that in mind, we have discussed the American Academy of Dermatology guidelines regarding the use of different biologicals in psoriasis. Now, the British Association of Dermatologists guidelines are a bit different. They don't mention anything about different biologicals separately. What they mention about different clinical scenarios. Okay, and I'm not going to go into detail in the British Academy of Dermatology guidelines because it's better. The guidelines are shorter. It's roughly about 20-22 pages long, and it reads like a book. It reads like a chapter. So, and the recommendations are given as a paragraph. So it's better if you I'll provide the link for the PDF in the description of this video. Go and read those guidelines. Trust me, you will have to read it only 1 or 2 times, and you will have some idea. You might not remember those guidelines, but you will have some idea what the British Association is saying and how to go about it. Okay, that should be the approach. I'm just summarizing important points. These are the points that we have not discussed in details in previous videos on individual biologicals, or these are the points that we have not discussed uh, in the American version, American Academy of Dermatology. If there's a similarity between American Academy and British Academy, I've not discussed that in detail. Before starting the British Association of Dermatologists recommendation regarding the use of biological psoriasis, I'll just mention what do we mean by this two. This two is superscript is the grade of recommendation. So one is better than two is better than three. Okay, so this is for example is level three recommendation as per the British Association. So I'm just mentioning each and every recommendation on the superscript. So, regarding the use of biologicals, it should be used only by specialists and there should be a multidisciplinary approach. That means person who is well trained in using biologicals should use biologicals in psoriasis. Okay, multidisciplinary means that if a patient has psoriatic arthritis, then rheumatologist should be also included in discussion. If the patient has chances of TB reactivation, then pulmonologist or an infectious disease specialist should also be roped in. So it should have a multidisciplinary approach while we're discussing what biological to be used in different patients. Arrangement of drug administration is also recommendation 2. That means if we are giving IV drug, then the patient has to be educated that they need to get admitted for IV infusions. If we are giving subcutaneous drug, then make sure that we educate the patient for self-medication. We give initial doses ourselves, but then we have to educate the patient also. Now focus on participation in registry, that is grade of recommendation 3. Now this is for the British Association. They have certain registries which collect data regarding the efficacy and use of different biologicals. So we should encourage the patients to get enrolled in certain registries so that they can report the specific changes, specific improvement, and we have much more data so that the guidelines get better. Okay. Now, criteria for starting biologicals means if there's significant psychosocial impact, that means DLQI is more than 10, or if there are clinically relevant psychological symptoms because of psoriasis. So that's grade of recommendation 2. If the patient has failed treatment or improvement with methotrexate and cyclosporine, or in fact, it should be and or. Okay, failed treatment with methotrexate and or cyclosporine, that's grade of recommendation 2. If the body surface area is more than 10 or any surface area which is causing functional impairment or distress, grade of recommendation 2. Start early whenever possible. Whenever possible, you want to start a treatment therapy regimen for psoriasis, consider biological as early as possible. If any general treatment which you are giving which is non-biological in origin, if it fails, then it's better to consider biologicals. Recalcitrant. Now, what is recalcitrant? That means even after giving any therapy, any non-biological therapy for 3 months, there is still more than 50% increase in baseline activity of psoriasis, then this becomes recalcitrant. So, in recalcitrant psoriasis or psoriasis which is persisting at difficult to treat areas like nails, scalp, these all patients become one of the perfect candidates to be given biological therapy. Now, regarding prescribing or reviewing the biological, before prescribing, we should be aware of all the benefits and all the benefits should be discussed with the patient. High quality evidence based information should be provided. So, if the patient asks for high quality recommendations, RCTs, different studies, we should provide, as a doctor, we should provide them. Provide support and all the evidences. Provide psychological support also with the biologicals, with the medicinal support also. You should discuss on every follow-up visit with your patient regarding the what all we are doing, why are we continuing this particular biological, at what point of regimen we are now, and what efficacy are we kind of approaching or we are seeing in our patients. So keep on discussing, keep the patient in loop, keep on making the patient apprised about their improvement, if there are any side effects appearing. So just provide support and review the patient on all visits. Keep on evaluating your patients at all follow-up visits. Review objective parameters, not subjective. Objective parameters like PASI or DLQI should be, reviewed. Also keep recording or keep reviewing the psychological status, whether there is any improvement in psychological status or whether there is no change or decrease in psychological status for the patient. Okay, keep an eye, because see, psoriasis is a very psychologically disabling disease. Okay, so it's better that you should have at every follow visit, just keep on asking questions about how do they feel, how are they liking this new therapy, is it making any change in their daily routine. Keep talking to your patient. Assess minimal response. Now what is minimal response? Minimal response is PASI 50. Okay, PASI 50 is 50% decrease in PASI. Yeah, 50% decrease in PASI from the baseline value. This is the minimal response. Okay, and this is assessed at 3 months. So there should be at least 50% reduction. If it is not happening, that means the treatment is not that adequate, and you may consider either increasing the dose or decreasing the interval between doses or adding on different combination, methotrexate, narrowband, etc. Consider change to alternatives if no response or there's a relapse or any biological is contraindicated. Okay. Now, choice of biologicals. What biological should you choose? Complete evaluation of the patient should be done. Consult the rheumatologist. Remember that TNF-alpha inhibitors act better on psoriatic arthritis. So if your patient has evidences of psoriatic arthritis, let's say patient has evidences of arthritis on X-ray, okay, but there's no clinical symptoms or disabling problems, but you have signs on X-ray, so it's better to consider infliximab, okay, which is a grade A recommendation of decreasing the X-ray signs. So you may consider infliximab. Consult a rheumatologist. Make sure the patient is evaluated completely. Consider psoriasis factors, individual factors, and drug cost. Now, all of these factors are given in details in the British Association of Dermatology guidelines. I request you all to go and have a read of these guidelines, and they will tell you what are the psoriasis factors. That means itching, redness, irritation, visibility. Individual factors are psychological issues, functional impairment, drug cost. You cannot give a costly biological, because remember, biologicals will work as long as you're giving them. There's no end point to biologicals. So we must keep drug cost into our mind, especially in our country where the patient would have to pay the major brunt of a biological therapy. Offer only licensed biologicals. No unlicensed biologicals to be offered by the patient, even if the patient asks for it. Offer TNF alpha or interleukin 17A antagonist first. That means you give all the 4 TNF alpha, plus you can also give Secukinumab first, rather than giving Ustekinumab or Certolizumab or Infliximab or others. Silrakizumab and others. Consider Etanercept if TNF alpha inhibitors are indicated and patient has failed previous biologicals. Now remember that Etanercept has, I would say, a lot of data regarding its use, and well-controlled studies, RCTs, double-blind, compared with placebo, compared with Ustekinumab, Secukinumab, other TNF-alpha inhibitors. So it's one of the best TNF-alpha inhibitors we have. So if TNF-alpha inhibitors are indicated, consider Etanercept as first. Consider Infliximab if there's very severe disease and patient has failed previous biologicals. Now, why Infliximab? Because remember that Infliximab is an IV infusion. So bioavailability is 93-94%. All of these biologicals are subcutaneous. Bioavailability goes around 55-60%. Okay, and Infliximab can be given every 2 months in maintenance phase. So it becomes a better biological in that sense. Okay. What to do regarding dose escalation or reduction in intervals in maintenance phase? Consider inadequate response or if weight-based dose change is needed. For example, you consider increasing the dose if the response is not good, or if because of weight you need to give a higher dose. But also take into account the side effects that you will have, that is increased chances of infection, theoretical increased chance of malignancies, increased chance of TB reactivation, increased cardiac issues. So all of these issues are seen with higher doses. So make sure that you take that into account also. If secondary biological fails, consider complete re-evaluation. Secondary is, let's say you start the patient on biological A Now you have to switch between A to B for whatever reason, and B has also not shown good benefit. So that means secondary biological has failed. So if the patient is failing the secondary biological also, completely reevaluate the patient, reevaluate all your decisions, what all biological should be considered next. Now in pediatric considerations, remember that very few biologicals have been approved for treatment in pediatric population. Okay, so some of them are Adalimumab, who have off-label indications as for use in psoriasis at ages 4 years and above, Etanercept at 6 years and above, and Ustekinumab more than 12 years. Okay, but the patient should have severe debilitating psoriasis, moderate to severe, and should fulfill the criteria for biological therapy. Then only you may consider those biologicals in those populations. Consult a dermatologist who is an expert in using biologicals in psoriasis. So it's better not to give if you don't have much experience regarding the use of biologicals in pediatric population. Now I would like to add that there is a separate guideline regarding the use of biologicals in pediatric population given by the American Academy of Dermatology, and it is available just side by side by the adult guidelines. So if anybody is interested, you can always go there and see. Regarding contraception and pregnancy, the British Association of Dermatology mentioned that whenever you are starting biological, strongly advise for a contraception. Make sure that your patient is not, likely to get conceived during the therapy. Although there are no interactions with available oral contraceptives or other contraceptives, so make sure if the patient can take OCPs, take OCPs. Okay? But remember, these are the contraceptives available to the British population. Okay, so these guidelines are not particularly efficacious or prudent in our population. So just make sure you know about that. Discuss the impact of uncontrolled psoriasis. Remember that if a patient gets pregnant, you have to discuss whether stopping a biological will lead to a flare up of psoriasis, and even a flare up of psoriasis can have significant impact on pregnancy. So discuss with your patient what all can happen to her if the psoriasis flares up just because the biologicals were stopped during pregnancy. Give all the evidences. Remember that all of these drugs have low risk as per the newer pregnancy category. One of the biologicals have either no data or low risk for using using pregnancy. The preferred drug as per the British Association of Dermatology is Certolizumab Pegol. Remember that this is a pegylated biological, and because of the pegylation, it lacks the Fc component and it is not able to attach to the fetal cells. Okay, so Certolizumab Pegol becomes efficacious. If you're using any other biological, consider stopping the biological in second and third trimester. Why second, third trimester? Because maximum transfer of IgG molecules through the placenta to the fetus takes place in second to third trimester. Instead, in second to third trimester, you can use cyclosporin or Certolizumab Pegol. It's better because, as I've said, they are safer in the second and third trimester. So with that, we have discussed the two major guidelines regarding the use of biologicals in psoriasis, the American Academy of Dermatologists and the British Academy of Dermatologists. But remember that for complete knowledge, you need to see the individual videos on each and every biological so that you have a better understanding how these drugs act and you can take better clinically oriented judgments when you're using these drugs. Okay, so please see the individual videos. These are the links for AAD guidelines and BAD guidelines. I will be copy pasting these links in the description box. You can copy and paste it into your URL box and go directly and read the PDFs in detail in full scenario. There is one article which I found to be useful, which is the biological use in Indian psoriasis population. I will also copy paste the link, so you can go back and read the whole article in their entirety, and you can then see this video at 1.5 or 2 times the speed, or let it put on earphones and just hear me out while you are just walking or doing your household chores. Okay, so with that, I finished the first ever video on guidelines in dermatology regarding the use of biologicals in psoriasis. Now, with this video, we'll finish the series on psoriasis. So we have done a series on non-steroidal drugs. We have done a series on systemic corticosteroids. We have done one video on pathomechanism of psoriasis, and we have done all sorts of videos on different biologicals which are used in psoriasis. And now we have done discussing the guidelines. So individual videos, I know they are long, but they, in my opinion, encloses everything which should be discussed and we should know about. So systematically, I've tried to go very systematically so that we may understand and remember easily what are drugs or what are biologicals to be used in our patients. So let me know in comments how did you like the first video on guidelines. If it goes well, then I might discuss other guidelines. I wanted to discuss CDC guidelines for STIs, and there's all sorts of Gallen guidelines for urticaria. So we would like to discuss that depending on what response this video goes. But this would be a last video on psoriasis for quite a long time, and I would like to switch to a different drug class for a few weeks. I've been reading about cytokines, chemokines for the last 2 months. So I would like to, spice things up and change to a different class. So let me know if you have any kind of issues, any kind of suggestions. You can email me directly on my email ID, or you can just write your comments, doubts, suggestions, how to make these videos better below in the comment section. Okay, with that, I would like to say goodbye, adios, and don't watch Adi.